the title of the session is how genetics will help human health, but really cancer is a big part of our discussion here, and how genetic discoveries are really transforming the prediction and treatment of cancer. I'm very pleased to have two excellent, super knowledgeable genetics experts with us today. Nicole Lambert, who's president of Myriad Genetics, and I'm going to ask her in a minute to tell us in a little detail what Myriad Genetics does. But among other things, Nicole is a genetics counselor and has a master's degree in that she got before she went into the whole business side of this. Meredith Salisbury, any of you who've been part of the techonomy community for even a relatively short while recognize her name, because she's been writing for us about healthcare and particularly genetics and genomics, the difference between which I always get confused, by the way. But she's been writing about those things for us for about 8 years. I think if you went to Techonomy's website and searched Meredith Salisbury, you'd find 60 or so stories that she's written, and they're all excellent. We just published a piece of hers this morning about the mRNA vaccines and how to think about them, what it really means that they were produced in a different manner. It's a beautifully composed explainer piece. I'm very proud of publishing that. So thank you, Meredith. Thank you for being here. But let's just quickly start with Nicole telling us what Myriad does, so that we get that out of the way, because I think that's important.
Sure, absolutely. Myriad Genetics is best known for isolating the BRCA1 and BRCA2 genes almost 30 years ago now. So those are the genes that predispose, most commonly to breast cancer and ovarian cancer. And we've been offering that service to women and men who have a family history of breast cancer for about 30 years now. As you mentioned, I'm a genetic counselor by training. I was a customer of Myriad's in the early days, and I've been with the company for about 20 years, and I've seen the company really rapidly evolve from out of just BRCA1 and 2 testing to a panel of multiple cancer predisposition genes, prenatal genetic testing, other testing within the cancer space, and even evolving into mental health and helping predict which patients will respond to different antidepressants. So it's been quite a journey and a really exciting one. It's moved really fast in some benchmarks, and in other ways it's hard to believe that we found these genes 30 years ago, and it still isn't exactly routinely offered or routinely accepted in the medical community yet.
Well, that's a topic we're going to get to. Why is that, and how can we fix that? The first thing I really want us to talk about is just where we stand with what's called precision medicine, which is the use of genetic techniques to evaluate human health. Meredith, I'd love you to just tackle that one. How would you say we stand right now? And maybe then we'll come back to you on the same point, Nicole. Where do we stand with precision medicine in American healthcare?
I wish you were asking me that 20 years from now, because I think I could say we're doing great. Right now, we are, I think, doing as well as we can, and that's not as well as we would like, but we're getting there. We've made tremendous strides in understanding different genetic variation and how that relates to human health, and how that might tell us things about, this person will do well with this drug, but not that drug. So we've made real strides, and I think there's a lot to celebrate, but we're still very early in the discovery phase of understanding the genome. Even something like the BRCA1 and BRCA2 genes that Nicole mentioned, we're still learning about those, 30 years of study, and we're still finding new things about what those genes mean and how we can use that information for health. So as I say, I think a couple decades from now, we will be well into this. I think it will just be a standard part of all healthcare. But right now we are in the early phase, and there are growing pains.
Well, thanks. Well, obviously we have way more to learn about our own genome. I think I used the word right. But Nicole, given we do know a certain amount of key things which your company and other companies are taking advantage of, how are we doing taking advantage as a medical system in the United States of what we do know?
Yeah, I think it's variable. I agree with Meredith completely. There's, scientific advances, but oftentimes, education, physician education doesn't catch up with those very quickly, or we don't know how to interpret certain genetic variations. And of course, educating the public and private payers about the value of precision medicine, the validity of precision medicine, has been an uphill battle, right? We know that this is an industry where there's a lot of trust. We learned recently from the Edelman Trust Barometer that there's a lot of interest and trust in the personalized medicine industry, which is exciting, but that 78% of people still just really don't understand what it is or how it works. And so it's difficult, I think, for consumers to ask for it if they're not exactly sure what it's going to do for them, or how accessible it is, or how well validated it has been. And it's very difficult for payers, I think, to go through a tech assessment for personalized medicine, right? Because back in the days of BRCA1 and 2, there were a few genes that we focused on, and it was clear what the implications of those mutations are. Right now, payers are getting inundated with new genetic tests and new personalized medicine tests every day, and it's difficult for them to keep up with a tech assessment of that.
Meredith, I know one thing you've written about for us is this issue of doctors themselves not understanding genetics or genomic medicine. Explain how bad is that problem, and are we taking the right steps to alleviate it?
So, you have multiple challenges here. So right now, if you're a patient at a top tier academic medical center, your physicians are very well versed in genetic testing, how to use it, when to order it, exactly what kind of information they're going to get. If you are one of the vast majority of patients who goes to tertiary care hospitals, regular community hospitals, your physicians may not be as up to date on that kind of information. So the initial challenge is that there's not enough focus on genetics in medical school, right? It's just a tiny sliver of what they learn. So they don't have a great foundation coming out of medical school. And I believe that's getting better over time, but most physicians in practice today went to medical school long before that was addressed. And then you have the fact that it's really up to each physician to get out there proactively and educate him or herself about what's available and when to use it. It's a huge hurdle.
Yeah, interesting. And again, it sort of goes back to that session we just had. I mean, the disparities, inequality, it's another case of American inequality writ large, really, which is so tragic. But let's segue to what we can do with genetics now. And Nicole, maybe you could talk a little bit about what the data that Myriad gathers is able to tell us.
Right, so for most of what we do, it's genetic testing for breast cancer, right? And so we've gathered a lot of data over the past 30 years about genes that predispose to breast cancer, what the relative risks are if you have mutations in different genes. And most recently, we upgraded our genetic test. What we found is that, not all breast cancer is a straight genetic inherited predisposition, right? There are people that have a higher risk for breast cancer that we're not able to identify a mutation in certain genes. And so, but their risk is not zero and is not back to the general population. So in the early days of genetic testing, we would order a panel of genes. We would say, okay, you're positive, and the likelihood that you get breast cancer is up to 87% for something like a BRCA1 or 2 mutation. Now we're able to look at many more genes, but also we're able to be much more precise about exactly what the risk is, and also the time frame. So if you have a mutation in a different gene, the risk could be lower than that. And also we've recently added a what's called a personalized risk score to those patients that test negative on the hereditary panel that will give them an exact number, right? So we'll say your lifetime risk to develop breast cancer is 58% or something. It's much more precise and exact than anything that we've had previously. The other question that I often would get from patients, and I wondered myself even, right, was just because I have this lifetime risk, if I'm in my 40s and this risk goes up until I'm in my 80s, when exactly do I have the most risk, or when do I need to do something about that? And that was also something that we didn't know a lot about previously. Patients would be told up to an 87% chance over your lifetime. But the question they always came back with was, okay, do I need to do something about this in the next 2 years, in the next 5 years, in the next 10 years? Like, when do I act on this? And with our latest enhancement with risk score, we're able to give patients a lifetime risk, but also a 5-year risk. And that helps, I think, especially as we look at, younger women that are undergoing testing, that are unaffected, they've never had cancer before, and they're, starting off their careers, they're starting off their families, and, frankly, they don't always have time to undergo a surgery or to undergo, multiple rounds of screening if that's not necessary. And so that 5-year risk gives them a little bit more visibility into, yes, you might have a really high lifetime risk, but your risk in the next 5 years might be really small, right? So if this is something you want to put off a little bit, you're probably okay.
Now, do those more exact lifetime risks and the 5-year risk analyses arise from an examination of a different part of the genome? Where is that information coming from?
Yes, that information is coming from what's called single nucleotide polymorphism. So there are other loci within the genome that are predictive of what a woman's lifetime risk is for breast cancer. So we're not just looking at BRCA1 and BRCA2. We're able to sort of look across the genome and look for sort of so-called hotspots that really are the best predictors of breast cancer risk.
And that's because we've just learned more about the correlation between people who get sick and the nature of their genome over the course of time.
Yes,
right.
Absolutely.
So Meredith, I know one of the things that has, it takes a little wrapping one's brain about the thing we really can learn from genetics is inherited susceptibility, right? Talk about what genetics tells us about our likelihood of getting sick in general.
Yeah, so again, we're learning so much. One of the easiest things we have is, for like Nicole was talking about, these families where, they know that breast cancer runs in the family. And even that is a relatively new concept, right? I mean, 50 years ago, it was considered crazy to think that cancer risk might be hereditary. But those families can now get information. For example, I'm a customer of Myriad as well, because I come from a family that has a known BRCA1 mutation. And so I got myself tested and found out that I do not carry that particular mutation. So that was a huge relief for me. So people in lots of kinds of families, families where there's
quickly, the reason you did that was because several of your relatives unexpectedly got cancer. Is that correct?
That's right. It was like a freight train hitting the family all of a sudden. And so, that's not just for breast cancer. There are, a lot of diseases have a genetic component. And so as we come up with new genetic tests, more and more families will be able to get that kind of information. But there are other things that we're learning, and things like, how not what's in your DNA, but what's in your RNA. So which genes are turned on, what's active. That can tell you about things in your health that are not necessarily inherited. Those can be things that are triggered environmentally, or, whether you smoke or drink or things like that.
And so, Nicole, I know one of the things that I didn't even know Meredith was a customer of Myriad. That's not why you're here. That's funny. I mean, not funny. It's apt. But now you have another test where you're testing for a lot of other different kinds of cancers, which does sort of say a lot about what we're starting to learn about inherited susceptibility and the risk of cancer. So just talk about what that bigger test is and why somebody might want it.
Sure, absolutely. And first of all, I'll say, Meredith, what a great, empowering story. And I'm glad that we were able to provide that risk for you. I think that's the most powerful genetic test that a family can get, right? Where we say, we know exactly what's causing cancer in this family, and you have not inherited it. So that truly right there, your story captures the power of genetic testing. So thank you for sharing that, for being willing to share that with others. That's a great outcome for you and your family. In terms of you know, what the expanded panel does, I think it's a couple of things. So again, when we first launched at Myriad, actually, we only tested for one gene. We only tested for BRCA1. Today, we test for 35 genes, for 35 cancer susceptibility genes. And so the difference, I think, is, you know, previously we were just looking at breast and ovarian cancer, and we were just looking at one gene. Now the panel that we have with 35 genes looks at the 8 most common cancers. And what you often see as the genetic counselor is a family walks into you and they don't just have breast cancer, breast cancer, breast cancer. They've got, you know, breast cancer, someone had prostate cancer, a cousin had colon cancer, and it's very difficult to sort out exactly what gene should you be testing for. So again, in the earlier days, we would start maybe with BRCA1 and 2 because it was easier, it was covered by insurance. But then if that was negative, we would start going on a hunt for what other genes might be causing cancer in this family. And what we're able to do now with these larger panels is to screen across multiple genes, across 35 genes, and again, address all of those common cancers that a patient might present with somewhere in their family history, and give them a result right away, right? So it's one test, it's, you know, 1 week's turnaround time, instead of this test is negative, we're going to try something else. This test is negative, we're going to try something else, which causes a lot of delay in treatment and a lot of anxiety on the part of the patient. We're able now to quickly, easily, and efficiently look at the 8 most common cancers, look at the 35 genes that are known to be, you know, associated with those cancers and actionable in terms of making clinical decisions, and get patients results very quickly.
Now, presumably anybody could get these tests, but who are the people that should get that test?
Good
the 35
question.
Cancer test.
Good question. You know, and that's a really personal decision, right? I think our goal at Myriad is to make testing as accessible as we can to any patient that wants to undergo testing. Typically, what you see from Physician Society guidelines and the National Comprehensive Cancer Network, right, is there's a recommendation for patients with a family history of cancer to undergo testing. More recently, probably the most liberal guidelines come from the American Society of Breast Surgeons, who recently came out with their society guidelines that state that all women who have had a personal history of breast cancer should be eligible for genetic testing.
But I mean, for all these other different kinds of cancer, say, you know, I wanted to go in and just say, what are the chances I might get cancer? I mean, there's 35 I could knock off by getting this, or I don't know, is it testing? It's 35 genes. Is it test for 35 different kinds of cancers? Or is that, it's
35 genes, it tests for the 8 most common types of
8
cancer.
most common cancers. So I thought I had that wrong. So,
And
but
just a second, David, those are all, if I have this right, those are all inherited susceptibilities. You're not
Correct.
actually testing for the presence of cancer.
Correct.
Right.
Just to be clear.
But Meredith,
Yes.
since you're talking, let me ask you this. And I mean, I guess we should, maybe I should finish off with Nicole on the question of, some people might just not need to know because they don't have cancer in their family. Is that sort of the way one would roughly judge whether they were a candidate for that kind of a test?
I think if you have no cancer in your family, you're unlikely to test positive, right? And so that's why there would be some skepticism of, do you really need to undergo this testing? And your, you know, insurance company might be skeptical of, you know, would they pay for this type of testing for you? But again, there are many people in America. One of the professional society guidelines says, you know, if you have a limited family structure or a truncated family history, there are people who, you know, are adopted, who have small families, you know, and they don't have a lot of information, right? You know, some people walk in and say, I have 4 aunts with breast cancer. Other people walk in and say, you know what, I don't even have 4 aunts. Both my parents were only children, and, you know, we just don't know much about the family history. And so there are cases where people like that, you know, are eligible for testing.
Okay, somebody, Jim Conley in the chat asked, what are the 8 most common cancers?
Right, so we're really looking at, you know, breast cancer, colon cancer, pancreatic cancer, melanoma. What else are we looking at? But basically, your most common cancers that you would see. The only one that I would say is, you know, kind of most common that we don't really look at is lung cancer, and there just hasn't been a lot of evidence in the literature that lung cancer is hereditary. So, you know, other than that, I would say we cover the most common ones that you probably would see in your family history.
And I should mention on Thursday, we have a deep dive on colon cancer issues that will really be worth attending because you know, everybody needs to be aware of the risk of colon cancer. It is very much more common than most people realize. Meredith, what I was curious to ask you, I started to ask before, and now I will ask, is there likely, in your opinion, to come a time when we could somehow, through genetic analysis and correlation of increasing populations, begin to say, you know, this person is likely to get cancer, period? In other words, is that the kind of data we might acquire as we come to know more about the genome? And then once we learn that, then we could do more exacting testing on such people?
Well, I think that's a great goal. I don't know that it's going to be possible for every single person, but already we're making progress toward that. So, you know, scientists can look at things called circulating tumor cells or cell-free DNA. So even in the earliest stages of cancer, some of it kind of sloughs off the tumor and circulates in your blood. So genetic testing is able to show at very, very early stages now the presence of cancer, and then you have to do some scans and kind of hunt it down. But we are being able to learn very early on when people are starting to develop cancer. I also think that over time, we'll have a better understanding of the specific cascade of mutations that happen in order to cause cancer. So we know it's not just one change, it's a series of changes over time. And so it could be possible to start detecting those very early changes kind of when it's precancerous, and maybe, you know, either monitor that person more closely or take some kind of intervention to make a difference.
What is believed to be the percentage of all cancers that are caused by heredity as opposed to environmental and other factors?
So I think the number right now is around 10%, 10 to 15, something like that. But I will caution that that's based on what we know right now. And we've learned so much, and we will continue to learn so much. I think that number could change significantly.
Okay, talking about learning more, one thing you've written for us about also is the All of Us study. So talk about that, and what is it and why does it matter?
So around the globe, we're seeing these very large scale genomic studies being done. So, you know, 100,000 people, 1 million people. And one of the great things about that is as we bring more populations into, you know, very intensive genome sequencing, we're going to be able to expand the application of precision medicine to more and more groups. So All of Us is a program that was started here in the US by the NIH. And its goal is to, you know, round up 1 million people, perform genome sequencing and lots of other kinds of studies. And then, you know, focusing very heavily on communities that have not been represented well in genomic databases yet. So we know that genomic databases are heavily skewed toward people of European descent. So one of the goals of All of Us is to really get to the underrepresented groups and make sure that those people are, you know, having their genomes analyzed so that we can learn about the important mutations for everybody's health.
So to a large degree, it's an attempt to remedy a historic bias towards white test subjects. In fact, you wrote a piece for us a year or two ago called "Welcome to Genomic Medicine - If You're White." Clearly, disparities and racial, you know, literal racial biases in the data are a serious, serious problem. And I know that's of great concern to you too, Nicole, if you want to comment about that.
Yes, absolutely. I think that's been a challenge for us across the entire industry, right? Is that in some of the historic research databases, those databases are biased towards more of a Caucasian population. And even, you know, as we look at the 30 years of testing data that we've accumulated, we've tested now over 5 million people. In the early days, when I joined Myriad 20 years ago, the overwhelming majority of patients that got tested, you know, were Caucasian. As we fast forward to today, you see much more diversity. where the majority of our patients do not have 100% European ancestry. And in fact, about a third of the patients don't have any European ancestry at all. And so that allows us to gather more data and understand the differences, which differences, are polymorphisms, which differences are significant, which differences, would give rise to a different course of disease. It just allows us to understand much more about diverse populations and to ensure that the validation is just as strong, no matter which ethnicity you are, which test you're undergoing. You're able to get just as precise and accurate information, no matter what part of the world you're from.
And presumably the All of Us data will benefit every company in the industry that's doing genetic analysis. That must be a huge asset once it comes into existence, right? Yeah.
Yeah, I mean, so it's publicly produced data, so it should be free to everybody.
Yeah, it will be, I guess. Okay, last question for either or both of you. Where is this all going? I mean, how quickly are we going to get to even more dramatic ability to predict and intervene before it's too late with human health, even beyond cancer? Meredith, why don't you start?
So, personally, and anyone who's suffered through my articles on techonomy knows that I am a huge in favor of everyone getting whatever kind of genetic test they want, regardless of what the doctors think, regardless of what any kind of gatekeeper tells you. I think genetic testing should be free to everyone for whatever application. And I think, people who don't want that kind of testing should be able to avoid it. But I would love to see people be able to make not just healthcare decisions, but also estate planning decisions, lifestyle decisions, all of these things based on what we can tell about the genome. And I think that that's realistic.
I do too. I think
that's coming. Yeah. Go ahead.
I do too. I think I'll give an example from our mental health business. I mean, I think it's so exciting, the advances that we've seen in treatment selection, right? And that it used to be that the prescription of antidepressants was really trial and error. And often, patients had to fail 3 lines of therapy before they were able to get a personalized medicine test. And often when you see patients that have gone through that journey, finally did get a personalized medicine test, they got put on an antidepressant that was effective for them, it was life-changing for them. They would say, I became a completely different person. I was back to being myself in just 5 days. I mean, people have these amazing stories of what the right treatment at the right time for the right patient actually does. And so I think we're getting to that point now where this is going to advance to, no one should go on an antidepressant at all without having a personalized medicine test, understanding which one will work for them, and avoiding that whole trial and error journey.
Wow, that's a great way to end, and with a great optimistic prediction like that. There's so much more we could discuss. We've run out of time. I think I've gone over time, but I really think it was a great conversation. Thank you, Nicole. Thank you, Meredith. Meredith, write more for us. We love your writing. And Nicole, really good to have you, get to know you. So thank you again.